Hello everyone, my name is Dr. Pradeep Shenoy from Pacespro. Now in this lecture we will be discussing about infectious diseases. As we know that infectious disease again constitute about 14 questions or 200 for the MRCP Part 1 exam. And the most important infectious disease is HIV and malaria. So both these group of diseases constitute about 30% of the question under infectious diseases. So today we will look at HIV. As you know that HIV virus is an RNA-made virus which is enclosed in the capsid. The capsid contains three important enzymes, that is reverse transcriptase, integrase and helicase. In addition, the viral cell wall which consists of lipid envelope, and on the top of lipid envelope we have the transmembrane glycoprotein GP41 and the docking glycoprotein which is the GP120. So this is the structure of the HIV virus. We know that the RNA virus enters the host through CD4 receptors, and on the virus we have glycoprotein 120 which is a docking receptor which is required for the entry of the virus. In addition, the host entry is facilitated by the co-receptor. They are either CCR5 or CXCR4, and this is the reason that the immune cells are one of the host for the HIV. And once the HIV enters the host, there could be a series of reactions in the host which are together called as seroconversion, which could be symptomatic in up to about 60 to 80% of these patients. So generally seen about 3 to 12 weeks from the initial infection. So they can present with sore throat, they can present with lymph nodes, myalgia, arthralgia, diarrhea, rash or mouth ulcer. So this spectrum of presentation is quite non-specific of any viral illness, and the differential diagnosis at this point would be cytomegalovirus infection, which is predominantly has a hepatitis, or could be Epstein-Barr virus infection. Remember that the seroconversion stage is followed by asymptomatic stage for about 5 to 10 years, subsequently development of acquired immunodeficiency syndrome. Remember in the exam that the question stem will usually reflect that the person is a business traveler who has recently visited Africa or Southeast Asia and subsequently presented with the above symptoms. How do you diagnose? Diagnose by using a fourth generation test, which is a combination of antibody test and the antigen test. However, the gold standard is detection of the viral RNA by doing a PCR test. Now, this is a picture of the time course of the event which occur after acute seroconversion. So we will focus on the first curve, which is the HIV RNA. So remember that HIV RNA is the first test which can be detected in a patient who is in the incubation phase. So HIV RNA level increases subsequently, the host immune response takes over and there will be a stable HIV RNA level. The second one to appear in the blood is the HIV P24 antigen, subsequently the antibody. Now, the HIV is diagnosed on a clinical suspicion of multiple symptoms. One of the common symptoms which with HIV presents is the recurrent or the chronic diarrhea. If you have a diarrhea disease in a patient with suspected HIV, so what are the differential diagnoses? So first and foremost, it could be Cryptosporidium. Now we know that it's an protozoa which is predominantly intracellular. It is one of the common causes of diarrhea in the patient with HIV. It has got a very short incubation period of 1 week. The characteristic feature of Cryptosporidium induced diarrhea is that it's profuse, it is non-bloody and it's watery, and it is associated with the high alkaline phosphatase. This is because Cryptosporidium, being a protozoa, has predilection for the biliary tree. You can diagnose Cryptosporidium by doing a simple stool examination, which will show oocyte with modified Z-Nielsen stain. You can treat the Cryptosporidium by starting the patient on antiretroviral therapy, or in the United States they use nitazoxanide. The second opportunistic infection which is suspected in a diarrheal disease is Mycobacterium Avm intracellularly. It's an atypical mycobacteria, generally seen in when the patient's CD4 count is less than 50. The patient here will have a systemic symptoms such as fever, abdominal pain, hepatosplenomegaly with altered LFTs, and severe diarrhea and weight loss. You can diagnose this infection by using a blood culture or a bone marrow examination which might show mycobacterium. You can manage this with the rifampicin, ethambutol, and clarithromycin. Giardiasis, it's an infection which is commonly seen in predominantly those who are dependent on the lake water for consumption. So there is a large outbreak in St. Petersburg in Russia. Remember, a recent travel to Russia might indicate that the patient might be having giardiasis. So it's an infection which has got a median incubation period of up to 3 weeks. The patient can present with lethargy, bloating, flatulence, and abdominal pain. It's a non-bloody diarrhea and some malodorous stool, so it's difficult to flush. You can diagnose this by doing a duodenal fluid aspirate, which is rarely done, or a string test, where we can see the microorganism. Treatment is with metronidazole, and it's quite effective. If you have a bloody diarrhea in a patient with a severe low CD4 count, then you should also suspect CMV colitis. Now, CMV colitis is an invasive diarrheal disease, so you should have a strong suspicion, and the diagnosis is based on the biopsy on the colonoscopy. Thank you.